Good afternoon, good evening, or potentially good morning to everybody, wherever in the world you are, and welcome to the first webinar in our series on rehabilitation in conflict. My name is Pete Skelton from the World Health Organization, and I'm going to be the main panelist on the session today. Very quickly, the agenda for today. We begin with opening remarks. We'll then have an introduction to conflict. We'll discuss the role of rehabilitation in conflict and the key challenges that arise, and then we'll have time at the end for questions. I want to thank everybody for attending. We've had a huge amount of interest from many different countries around the world, particularly those countries that are affected by conflict at the moment. So thank you again. And without further ado, I will hand over now to Mike Landry, who will provide the formal opening remarks on behalf of our hosts, World Physiotherapy. Mike, thank you very much.
Well, thank you very much, Pete. Salam alaikum, bienvenue, and welcome to this very important session, this very important webinar. I'll continue in English because we have excellent translators who will be working through this. So please select the language of choice. But again, a very warm welcome to all of you here today. I'm inspired by as I'm watching the chat and everyone introducing themselves from all over the world and places that are currently under conflict, under emergencies, and those who might not be at the moment. But we come here together today as a global rehabilitation community, united not only by our professions, the different ones, but by our shared commitment to humanity, dignity, and care in the most challenging of circumstances. Attending with us here today are Pete Skelton from the WHO, Erica Bleakley, WHO, Thanos Gargavanis, WHO, and le Dr. Charles Marcos from the Lebanese Order of Physiotherapists. This webinar series represents a powerful collaboration between leading international organizations, including the World Health Organization, the International Society of Physical and Rehabilitation Medicine, the International Society of Prosthetics and Orthotics, the International Spinal Cord Society, the World Federation of Occupational Therapists, and World Physiotherapy. Together, we stand in solidarity with those affected by the ongoing and protracted conflict in the Middle East and with the professionals working tirelessly to support them. We are also deeply grateful for the partnership and engagement of humanitarian organizations, including the Red Cross, Médecins Sans Frontières, Humanity Inclusion, Interburns, and many, many others. These organizations are on the front line, delivering essential care in complex and often extreme dangerous environments. Their work reminds us of the critical role that rehabilitation plays not only in recovery, but in bringing hope, function, and indeed participation. At World Physiotherapy, we're committed to supporting our member organizations in the region, as well as individual physiotherapists and the broader rehabilitation community. This includes occupational therapists, rehabilitation medicine physicians, speech and language therapists, and many others whose skills are essential to the comprehensive care into the future. In times of conflict, collaboration across professionals is not only optional, essential. We recognize the immense pressures faced by the rehabilitation workforce in conflict settings: limited resources, disrupted systems, personal risk, and the emotional toll of caring for those affected by trauma and displacement. Finally, I would like to extend our sincere thank you to our volunteer interpreters, Inaya and Roxanne. Your contribution ensures that this conversation is accessible to a broader and wider audience and reflects the inclusive spirit of this global rehabilitation community. Communication is at the heart of collaboration, and your work makes that possible here today. Pete, I'll pass it back over to you, but thank you for your comments, and we look forward to your words here today. Thank you.
Thank you very much, Mike. I would now like to hand over to Dr. Thanos Gargavanis, who is the WHO Eastern Mediterranean Regional Office Trauma Advisor. Thanos, over to you. Thank you.
Dear colleagues, thank you very much. It's an honor and a pleasure to be with you. And I would like to say that we will not be able to deliver all this without the sincere support from all stakeholders that work in physio and rehabilitation. We're deeply grateful. Now, for the World Health Organization, physiotherapy and rehabilitation makes a very important part of the trauma pathway. And by talking of the trauma pathway, you talk of all the steps an injured person should follow from the point of injury to rehabilitation until they're able to go back to the society as competent members to continue gaining the bread of the family. Uh, as this and as very important part, we try to make sure that when we support online operations, field operations, um, presence on the ground in conflict and in adverse situation, we make the best to make sure that physio and rehab plays an important part. It's not only with the technical support and physical support on the ground, but also there's an important component that has to do with making available all the necessary pieces of equipment and supplies that recently have been standardized. So we're happy to be saying that there's a set of trauma and emergency surgical care kits, test kits, that are dedicated solely for physio and rehab. Having said all that, I would also like to highlight that again, we are here to amplify the work of stakeholders and of partners on the ground. And it's a big honor to be here with you. Thank you very much.
Thank you very much, Thanos. I now hand over to Dr. Charles Morkos from the Lebanese Order of Physiotherapists, one of the organizations heavily involved in conflict-affected countries at the moment, and indeed one of the requesters of the webinar series. Thank you very much, Dr. Morkos. Over to you.
Good evening, everyone. مرحبا للجميع. Thank you all for being here today. Seeing such a large number of participants, colleagues, experts, and members of different organizations gives us something we truly need in difficult times: hope. It reminds us that even in the hardest times, people continue to care, to learn, and to strive to make a difference. Our presence here reflects a shared commitment to improving how we respond, care, and stand together in times of crisis. This webinar series is more than just a set of sessions. It is a space for discussion, reflections, and shared experience. That is why we are here today to talk about early rehabilitation and the role of rehabilitation professional within the crisis set. In emergency situations, saving lives is naturally the first priority, but what comes next is just as important. This is where rehabilitation begins. Traditionally, rehabilitation was considered as later step after surgeries and stabilization. Today, we know that this approach is no longer sufficient. Rehabilitation must start early, from the very beginning of care. To understand why this matters even more, let us reflect on the Lebanese context. Lebanese has faced many difficult periods over the years. During the civil war, survival was primary concern. Healthcare systems were weak, resources were limited, and rehabilitation was not part of the immediate response. As a result, many people lived with long-term disabilities, not because recovery was impossible, but because it started too late. Over time, this perspective began to change. The role of healthcare professionals expanded, and physiotherapy became increasingly recognized as an essential part of recovery. In 2020, the Beirut port explosion injured thousands within seconds. We all remember this fear, the fear and the pain of that day. but also the remarkable response of healthcare workers. Among them were physiotherapists who stepped in early, initiating rehabilitation from the first moments of care. In 2024, the war once again reminded us that crisis can arise at any time. Many people were displaced and injured. Care extended beyond hospitals into shelters and communities. With displaced people, especially with disabilities, and the role of rehabilitation professional became even more visible and essential. Early rehabilitation was no longer just a concept, it became a reality. Within the evolving healthcare context and the growing recognition of the importance of early rehabilitation, the Lebanese Order of Physiotherapists, in collaboration with Humanity and Inclusion and the International Committee of the Red Cross, established the Early Rehabilitation in Emergency Crisis framework in 2023, and a series of workshops were conducted with the help of those organizations mentioned earlier, and also with the collaboration of UK Med and Interburns. Following extensive efforts and the development of several key documents, this initiative successfully contributed to the formal integration of physiotherapists as essential healthcare providers within emergency response systems, after the approval, of course, of the project by the Ministry of Public Health. Today, in 2026, the whole region continues to face conflict, and many other countries are also affected. The situation is still testing our healthcare system and every professional within it. Rehabilitation is important not only for those injured, but also as an essential health service for people displaced, especially people with disability, and we shouldn't forget that. So once again, we are called to act. Rehabilitation professionals should not wait until the end of treatment to intervene. Their role begins from the earliest stages of care. Early rehabilitation saves lives, reduces complications, improves recovery, and enhances quality of life. This is why it matters. As part of the crisis cell, physiotherapists contribute by assessing patients, guiding positioning, supporting respiratory care, and planning early mobilization. They work alongside doctors, nurses, and other professionals, actively participating in decision making. Today's webinar is an opportunity to share experiences, learn from one another, and strengthen our practice in challenging times. In our context, being prepared is not optional. It is essential. To all the rehabilitation professionals here today, your role matters, your presence matters, and your early intervention can truly change lives. Thank you for being here, and I wish you all a productive and inspiring session. Thank you.
Thank you, Charles, for such powerful words. I think I could happily end the session now and everybody would take away the key messages and inspiration from the speech. So thank you very, very much. Thank you also to Mike and to Thanos for their introductions as well. And welcome again to everybody for the first in the webinar series. My job is to introduce you to the basics of rehabilitation in conflict. Some of you, unfortunately, are very familiar with work in this area from recent experiences, and for others, this may be the first time that you have been involved, and other people may simply be interested in getting involved and supporting colleagues in need at the moment. So we're grateful to everybody for attending. My name is Pete Skelton. As mentioned earlier, I'm the Rehabilitation in Emergencies focal point with WHO headquarters, and here very much at the invitation of World Physiotherapy. I'm grateful to have the privilege really of walking you through this first session today. We live, unfortunately, in the words of the UN Secretary General, in times of new and growing conflict. So we see a trajectory really of conflicts increasing, particularly over the past 10 years or so, and this graph only runs until 2023, with growing number of conflicts around the world. Not only are those conflicts growing, but the number of fatalities as a result of conflict are also increasing year on year at the moment, and we see significant upward trends in that direction as well. Not only are conflicts increasing, but the nature of conflicts is also evolving. Until recently, the majority of conflicts around the world were really due to a rise of non-state actors and violence occurring within states. But over the last few years, we're now seeing an increasing rise of interstate conflicts, or conflicts between two states. We're also seeing, unfortunately, at the same time, a degradation of the so-called rules-based international order and of humanitarian law, which is creating increasing difficulties, particularly for humanitarian and medical responders. We're seeing new weapons being used, including drones, and the use of AI in warfare as well, which are increasing risks to population and changing the way that we have to think around our medical responses and changing the types of injuries that people have. We're unfortunately also seeing the renewed use of indiscriminate weapons like landmines and cluster munitions, and the increasing use of weapons, explosive weapons in populated areas with dramatic consequences, particularly for civilian populations. I just wanted to say a point very, very quickly around international humanitarian law. It's not an area that we will cover in any great detail today, but it's important, I think, to understand. So this is rooted really in the post-Second World War world and the Geneva Conventions and optional protocols that were agreed upon then. And there are two key points, really. One is around distinction, and that is that those who are not taking part or no longer taking part in the conflict should be protected. And also IHL places restrictions on the means of warfare, in particular weapons that are used, that they shouldn't have indiscriminate effects and they shouldn't cause unnecessary suffering or environmental damage. What we're seeing, as I mentioned, is an increasing degradation, really, of respect for these rules, increasing attacks on medical personnel, medical facilities, and transport. In 2025 alone, WHO has documented 1,348 attacks on healthcare, including all of those that are listed below. And unfortunately, trends in 2026 show that this situation is getting worse and not better. What we see in conflicts, and particularly focusing on the region at the moment, are a huge number of injuries. These are just selected dates, really, from conflicts, particularly affecting the region, which has been the focus of this webinar series. And you can see injuries numbering from the tens of thousands up to the millions, particularly in Syria. And more recently, in the conflicts that have been ongoing over the past few years in Gaza, over 170,000 injuries. In Iran, and I should say these figures are up to March, over 23,000 injuries. In Israel, over 5,000. In Lebanon, over 3,000. And unfortunately, these numbers do continue to rise. There are all kinds of problems, though, in terms of injury data. So we're often asked to estimate injuries in conflicts, but the truth is that every single conflict is different. So there is no such thing as a standard cause of injury in conflict or standard ratios of injuries that can be taken from conflicts. There are different methods of different governments or departments of counting injuries. So no one count of injuries is the same as the other or carried out in the same way. We very rarely have live data on injury type or severity, and almost never on functioning outcomes of patients who are injured. And this, from a rehabilitation perspective, is a major problem because we simply don't know what happens to people in the long term and what the results of our interventions are. From analysis that we did in Gaza last year, we found that over 20% of injuries were likely to be potentially life-changing injuries. So 1 in 5 of those with injuries having something like amputations, complex limb injuries, fractures, spinal cord injuries that require long-term care. Current top-line data that we have from emerging conflict or current conflicts as well indicates that the percentages may be slightly lower than this in Iran and Lebanon and others from publicly available information. But it is very, very limited data that is available at the moment. So as I mentioned, the causes of injuries in conflicts differ depending on the nature of the conflict itself. This is a snapshot from a household survey that was carried out in Mosul, looking retrospectively at the causes of injury and death. And you can see then, in a pattern similar to many modern conflicts now, the predominance of airstrikes and explosive injuries, so blast being the main cause of injury. And really this is true in the majority of conflicts that we see at the moment. A blast injury is particularly complicated from a medical perspective, from a surgical perspective, and also from a rehabilitation perspective. And there are a number of components to the blast injury that we need to consider. The first is the primary, which is the blast wave. So the blast wave is the overpressure that results from the explosion, and this can cause a wide variety of injuries, including blast lungs, so resulting in pulmonary edema and emboli, cardiac hemorrhage, neurological damage, including a silent brain injury, hearing loss due to membrane rupture or damage to the bones in the ear, ruptures of the eye, and gastrointestinal problems as well. And some of these may not be initially evident at the time of presenting to hospital. And then we get secondary injuries. So after the blast wave, then we have the debris which is thrown by the blast, shrapnel and other debris from within the environment, and that results in penetrating and blunt injuries to various parts of the body. And if you're close enough to the blast, you may also be thrown by the blast, and that is the tertiary impact of the blast as well. So impact of the individual with walls and the ground, and that can cause blunt trauma and other types of trauma as well. Those close enough to the blast may also have quaternary injuries as well, and that particularly includes burns resulting from the heat of the explosion and inhalation injury as well. And so we often see blast injury being associated both with penetrating trauma, blunt trauma, and burns. And lastly, quaternary issues are the more longer-term consequences of the blast, including infection, contamination, the consequences of shrapnel injury with different toxins and metals and radiation. So what injuries are likely to predominate, having caveated as we have, saying every conflict is different? Well, as I said, in Gaza, 20% of all injuries were potentially life-changing. There were more other injuries than that required rehabilitation. Those with long-term consequences, around 20%. There was a very high incidence of polytrauma. Injuries were complex and often open as a result of the mechanism. The majority of survivors had limb injuries, and particularly lower limbs being affected more than upper limbs. And it's reasonable at the same time to expect amputations, burns, spinal cord, and traumatic brain injuries. And you can see the estimated proportion of those injuries in the column on the right-hand side here. It's worth noting that a number of injuries may be missed, including moderate brain injuries, but the context really varies significantly from conflict to conflict. And to demonstrate that, a couple of pieces of research, again on the left, samples from Gaza. The reference for the research is at the top, and on the right from Mosul. And again, what you can see is a real pattern of polytrauma, but the domination of lower limb injuries, then upper limb injuries, but significant degree of head injury involved as well. What we do is we often break down injuries into sort of key injury types: fractures, amputations, spinal cord, traumatic brain, and burns. That's important for counting. It's important for teaching. But we need to not get too caught up on that, because no patient presents with a single injury like that in a conflict situation. We also need to be very much aware of the mental health side of things. So somebody injured in a conflict situation is likely to be distressed as a result of what happened to them directly. They're also unfortunately likely to have lost family or friends, homes, livelihoods, and themselves be displaced. So we need to move away from the idea of managing individual injuries, and as all of you, I'm sure, do, towards the idea of managing people. And people in conflict with complex injuries, with a wide range of different distress, may not be ready immediately sometimes to engage in a rehabilitation process. We have to consider the mental health components of equal importance. That's the short background. The important thing now is what then is the role of rehabilitation professionals and rehabilitation services. Essentially, we have two roles. One is we need to get in and we need to provide rehabilitation for those injured, so the surgeon needs that results from the conflict. Two is that we need to be able to maintain access to essential services that may otherwise be disrupted. So if you're a child with cerebral palsy or an adult with a stroke and you're living in the middle of a conflict, you still need access to the same rehabilitation services that you did previously, no matter whether the war is going on or not. So we need to consider both of these two things simultaneously. My colleague Thanos already described the trauma pathway, which was actually initially developed by the MRO office and others in response to the Mosul conflict. Will be familiar to many of you, and it has rehabilitation as the end stage, so rehabilitation and reintegration. But as was also stressed by colleagues from World Physiotherapy and the Lebanese Order, what we're trying to push for now is that rehabilitation should start as soon as possible. So rehabilitation has a role not just at the end point to get a person back to their optimum state of functioning, but really from as early as possible in the hospital process, beginning often in critical or intensive care, moving through ward care, into more specialized inpatient rehabilitation, and then onwards onto the outpatient or community level. So we need rehabilitation services throughout the continuum. And when we get breaks in that continuum, unfortunately, what happens is that sometimes we lose patients to follow up, or there are significant delays. And these can cause complications and result in people having poorer outcomes. That is just illustrated here with examples from different settings of rehabilitation in the hospital setting. Rehabilitation in specialist rehabilitation centres, rehabilitation in the community, and highlighting, again, the importance of rehabilitation for people who are displaced and the challenging environments in which they may be living. And displacement really should be considered a third critical area in which we need to work. So not only managing the surgeon needs and maintaining accesses to essential services, but meeting the needs due to displacement. And in Lebanon at the moment, as an example, where we see more than 1 million people displaced, then it's easy to understand those people come with a wide range of different needs, often have left homes in a hurry with very limited resources, so lack access to things like the basic equipment and supplies that they depend upon. We know from previous research that displaced people are likely to have significant needs. So this comes from research of Syrian refugees in Lebanon and Jordan. And around a quarter of those refugees had some kind of impairment. And you can see that the result of that is a combination of things due to injury, due to the conflict, but also chronic disease and underlying disability as well. And we see huge, huge numbers now in conflict of people displaced. And we need to really consider how we are protecting those people as they flee. They need access to rehabilitation services, they need access to equipment like wheelchairs and crutches, because without that, they can't access even the basic services that they need, or children are not able to attend education, and so on. So this really is not just a health issue, but also a rights-based issue as well. So what are the consequences of all of this for rehabilitation? Well, what we see is that we get huge increases in complex injury that we need to be positioned to be able to manage. We see the nature of injuries, as I've stated, being very complicated, with high rates of infection and lasting impairment. We see that patients have a very, very short stay in the hospital and then often are displaced when they leave hospital. We see that rehabilitation is often not prioritized from the beginning of these big conflict responses, although typically people do realize later the importance of it. We see that rehabilitation services are commonly disrupted, that supplies may be limited, that we often have a lack of personnel, or at least a lack of personnel where they're needed to be. And we see that the well-being of staff is badly affected. We also have a lack of cohesion and sometimes a disparity of access to services between civilian providers and military providers. And of course, from a humanitarian perspective, we are interested in making sure that everybody has access to the rehabilitation care that they need. In terms of numbers then, one of the challenges that we have from a rehabilitation perspective is that while numbers of hospital admissions may go up and down as a result of waves of conflict or mass casualty incidents, from a rehabilitation perspective, the number of patients with new needs as a result of the conflict then continues to rise almost exponentially. So we don't have a wave that goes up and down. We have just a growing number of people that require access to our care. As I mentioned, those injuries are often very complex as well. We talked about polytrauma and the complexity of the injuries. We talked about infection and the fact that the nature of blast injury then means that actually these injuries often have debris driven deep into them, often beyond what can be easily debrided, which can then create infection, but also that patients are living in insanitary environments, dirty environments as a result of displacement. And often surgeries may even be performed in some suboptimal environments because of other constraints. As a result of those constraints as well, we often get adjusted surgical management. So whereas people may be used to previously working with patients with complex internal fixation, in conflict, we see adapted management because of less time, less equipment, and lack of sterility, often in operating environments. We also see the growing and important role of mental health and psychosocial support, and that these patients are often also very, very distressed. And we see the issue of missed injuries, which is where patients are being managed in mass casualty situation. The focus is very much, as it should be, on life-saving care. But as a result of that, many injuries, like peripheral nerve injuries, may not be immediately obvious and may be picked up later, often in the rehabilitation process. In terms of prioritization, and again, this is slightly old research, but a key finding from learning around the Mosul conflict was that the post-operative and rehabilitation care warranted greater support, that the needs were inadequately developed and supported. And while the issue was eventually recognized, once it was, there was insufficient capacity to meet the needs. Now, we are learning lessons, and absolutely this situation is improving. However, this is still a common challenge that from the beginning of such conflicts, we are often late to properly integrate rehabilitation considerations. Mosul, we also evidenced the short stay in hospitals. So field hospitals were instructed to discharge patients within 72 hours to ensure that they had space. And we've seen this mirrored time and time again in conflicts since then. And often those patients are discharged not home, and not to a position where they can receive ongoing care, but often as displaced people to camps or into host populations where discharge is much more follow-up. There's much more challenging. So having systems in place where we can follow up on these patients and track these patients is incredibly important. We see service disruption, not only due to attacks on healthcare, but because staff are displaced, because supplies may be limited, or because services are deprioritized. Below is an example from Gaza, from one of our early situation reports that we produced, and you can see that the overwhelming majority of rehabilitation services were not operational. And a number, again, also partly operational. We had no rehabilitation services that were deemed to be fully operational at that point in the conflict. We also face a lack of equipment, not an issue in every conflict, but often in some. These are examples of where organizations have then had to actually improvise themselves and begin to do local production of crutches, local production of rehabilitation equipment that can be used. We also get donations of equipment sometimes, and these can often not be appropriate. They're just dumped onto countries without consideration for appropriate provision to patients. Finally, we often struggle with a lack of personnel or the lack of access. And what we can see is there's a direct relationship really between countries that are prone to conflict, which often have weaker, not always, but often have weaker underlying health systems, and countries that have low ratios of physiotherapists, and using physiotherapists really as a proxy here for rehabilitation professionals. So we can see the difference in numbers running down the side here. So a lack of professionals, but often those professionals not being in the right place as well. So what that means is professionals working in private practice, in sports rehabilitation, not being well embedded into the trauma care system and not being prioritized during the conflict. As I mentioned, the well-being of staff is also of critical importance. Rehabilitation professionals and all health professionals, often themselves directly affected by the conflict, also frequently displaced as well as a result of the conflict. And that means they're struggling not only to look after themselves, but also often their families, either young children or elderly parents as well. They face ongoing loss and disruption. So at the same time as trying to deal with the complexity of the conflict and provide services for people, they are also themselves victims of the conflict. And I take this opportunity to highlight an old friend of mine on the left, Abed, who unfortunately was killed in Gaza while working for Médecins Sans Frontières. So that is a summary of many of the different challenges that rehabilitation professionals can face in trying to deliver services. And the next session that we have will really focus on the solutions, and you will hear from a wide range of expert panelists who will discuss those things. But I do want to highlight that some things are changing for the better. We do have now in rehabilitation professionals well integrated into emergency medical teams that are being deployed on both national and international level in a number of conflicts. We see a positive role of coordinated diaspora in efforts, for example, in Sudan, in occupied Palestinian territories, and in Armenia. We have a growing number of technical and operational standards and guidelines now that include rehabilitation. So we don't have the excuse of not having anything written down that we can work from or use to advocate. We also have an increased prioritization now of rehabilitation in coordination structures and mechanisms. We have improved supply chain and often improved supply monitoring as well. And as WHO, we're really promoting now a shift towards national preparedness. And it was great to hear, I think, again, from the Lebanese Order of Physiotherapists, the work that has been undertaken there. Preparedness really is key to an effective response. There are, of course, as well, opportunities that present themselves to be able to strengthen rehabilitation in the midst of war. And I will come to that again in a little bit. I want to highlight that in 2023, we had a resolution at the World Health Assembly on strengthening rehabilitation in health systems. It raised concern. Countries were not well equipped to respond to the increase in rehabilitation needs generated by health emergencies, and it actively called on member states to ensure the integration of rehabilitation into their preparedness and response. And as WHO, we're working on a toolkit at the moment to support countries in that aim. Yes, very briefly on the work of WHO for those not familiar with us as an organization. So we are the UN agency with responsibility for health in Ukraine. We have led coordination efforts with the health cluster and also with the Ministry of Health. We're strengthening and expanding the availability of quality rehabilitation services, really with a focus on sustainability and national leadership. So ensuring that the conflict response results in a stronger, much more effective and much better integrated rehabilitation system. We're supporting the government of Ukraine with the development of technical standards, and we're supporting programs ourselves in specialist areas, including spinal cord injury, to develop services there for all those with injuries. We've also, as part of this, deployed a number of technical experts and provided supplies as well. In Gaza, we co-lead on the rehabilitation task force on the coordination side of things, and you'll hear from my colleague Amani next week, who is the coordinator there. We've supported the development of a wide range of technical standards and packages, which really ensure a consistent, effective, and very, very strategic response. So historically, challenges that we've had is very fragmented responses with lots of different agencies, essentially managing based on their own priorities and procedures and protocols, whereas we have a much more streamlined and coordinated response now. We're doing a lot of work which is focused on quality, and we look right the way through the rehabilitation system. So from tertiary care all the way down to primary care and community level rehabilitation services. And together with other colleagues work on projects including supporting limb reconstruction and the rehabilitation components of that. We've deployed technical experts. And again, we've mobilized significant quantities of supplies. As a community, then, we have a large number of resources that support us. We have guidance from emergency medical teams on responding to health emergencies in armed conflicts. Really, rehabilitation mentioned throughout this as a core component of the response. We have a policy brief on strengthening rehabilitation in health emergency preparedness, readiness, response, and resilience. And this contains a lot of the key information that's needed on a national level to work on integrating rehabilitation into this area. There is a clinical handbook which was developed in collaboration with most of the organizations, if not all of the organizations who are part of this webinar series as well. And that includes online trainings as well. And that's available in Arabic, French, and a number of other languages. There are a whole host of other clinical guidelines as well, which include rehabilitation, the better of which often ICRC and their war surgery guidelines, which has a really strong emphasis on rehabilitation. All of these are consolidated together with links on the WHO page on strengthening rehabilitation in emergencies. I want to finish with the point that conflict really is catastrophic for those involved and affected, but it does also present an opportunity for rehabilitation services because of the huge and often overwhelming needs that it generates. So conflict was the main driver of the emergence, really, of modern rehabilitation. And centres like Stoke Mandeville, which were established in the UK, and we continue to see conflict driving innovation within the rehabilitation sector. And that's simply because countries need to have to think about how they're going to manage rehabilitation now of a whole new cohort of often very young people with complex injuries that have long-term needs. I will stop at this point. Grateful for the opportunity to talk to all of you. And I will hand back to World Physiotherapy, who I think are going to come back with some questions. Thank you very much.
Great. Well, thank you very much, Pete, for your words of encouragement and detail. And while I have the opportunity just to recognize your longstanding commitment and passion in this field for not a decade, but multiple decades. So thanks for all of that you've been doing with the WHO and even before that with HI, et cetera, EMTs. But yes, this is sort of the question and answer period. I've been taking some notes here, but I'd encourage you all in the chat to put your questions there, and I'll sort of summarize them and bring them back. But Pete, if I could just start off a little bit here by picking up a little bit on one of your last slides around sort of innovation. Um, you're absolutely correct that, of course, that the many of our countries of all economic development or exposure to conflict have high levels of disability and rehab needs that are already not met. And then a conflict or an emergency scenario, results in an amplification of those needs. How what kind of innovative solutions have you seen in your exposure around the world to meeting some of these rehabilitation needs in innovative and new ways? I mean, quickly we could go to sort of tele-rehab, but what other sort of innovative strategies that you've seen that could be helpful here?
Thanks, Mike. And yeah, I think we kind of automatically go towards technological solutions at the moment in this area, but actually some of the innovations are more basic than that. So I think the world really was changed from a medical response perspective following the Haiti earthquake in 2010 when we generated these standards for emergency medical teams. So standardizing the medical response to emergencies. That meant that rehabilitation had to be included within the surgical response. Now, for us, that maybe doesn't seem that innovative, but at the time it was a fundamental change, I think, in terms of how these surgical teams responded to emergencies. What we're seeing now is an increasing transition towards more niche capacity that is needed. So a recognition that health systems have very specific gaps that they need to meet, and rehabilitation is often one of those gaps. So the idea that we can have specific rehabilitation teams that train together under the governance of a single organization, often under the coordination of the Ministry of Health, and can be deployed to provide rehabilitation services either into particular facilities where the needs are high, or even establishing standalone services, whether outpatient services or community services, to go out and actively reach people who have the greatest needs. And I think that is one of the major innovations that we've seen. I think data is a big part of this, and we still face a lot of challenges in terms of data. We don't have great injury data, not that's relevant to rehabilitation from most of these conflicts. There has been innovation with the use of minimum data sets and more standardized reporting that we're seeing now. I think a great thing that was done by WHO actually in Gaza was the implementation of a tracker, which means that we can see when patients are receiving assisted products, what they're receiving and at what point, and who needs them and who's waiting for them. And the next step from that, I think, is really to innovate and turn that into something which can actually track a patient's journey, so that we can see an injury, we can see that somebody has a need for rehabilitation, and we can begin to actually track that patient and see that they receive the care that they need, and where they don't, that we can follow up and sort of actively manage that process and ensure that that happens. Now, in a conflict, that's obviously complicated because of sensitivity around data and things like that we have to consider as well. But it does, I think, start to negate one of the main problems that we've seen, which is losing patients to follow up, which really is one of the single biggest challenges, I think, in conflict situations like this. I think local production is another thing. ICRC, MSF, I think really have been leading organizations in this area. So manufacturing of pitches, MSF making burn garments from patterns for pressure, burn pressure care, really, really important, and other areas as well. We also see challenges here where people want to innovate and they make do with the best that they can do, but they're making things like prosthetics from drain pipes and things like that, which you can really understand the need, but then we also have to worry about the negative consequences of that. So are we creating a product maybe that doesn't come to certain standards and is actually in the medium or long term going to harm the patient as opposed to help them? So innovation, but also ensuring safety as well at the same time. And of course, tele-rehab being possible, but in many contexts that we're working at the moment, the biggest challenge that we're facing is connectivity. So we have a more or less full connection outage covering Iran at the moment. In Gaza, connection has been on and off. In Lebanon, happily, we have very good internet and great to see so many Lebanese colleagues at the moment, but absolutely connectivity being a problem as well. But happy also to hand to colleagues on the panel if anybody wants to come in with examples. Thank you.
Yeah, thanks, Pete. Yeah, sort of interesting, I guess. I, like you, responded in Haiti, where internet access was probably one of the first times where it was relatively easy, and made quite a bit of difference, didn't it? But the point also is well taken that just because something is new, quote unquote, doesn't mean it actually is innovation. If it actually creates more challenges, and yet another event that happened for events in Haiti. So let's keep moving on here. I think there's been what you're saying here is wouldn't it be interesting to have a clearinghouse of some of the innovative approaches that different groups have been taking and using it as a learning tool. And I know that the EMTs, you have a knowledge hub, right, at WHO, which again is something, an important resource I think that everybody can know about. And maybe we can send that around to make sure it's well known. Another question that came up from, I'm just reading from my chat here, that came up from a colleague, I think it's Iman. I'll just read it out. At what point is in early rehabilitation are we trying to advocate for? So I think this is that proverbial, where is the acute and subacute and chronic? It might all be heightened in an emergency situation, but Pete, what are your thoughts on how we consider, or what we consider to be considering, let's say, early?
It's a fantastic question. For me, early is as soon as possible, but we need to have the right skills to be able to work in that context. So, for example, we have rehabilitation professionals sometimes working in emergency care where we have mass casualty situations coming in because they can be trained and it can be within scope of practice to work with minor injuries or to provide crutches for sprains and so on. We have rehabilitation professionals working in critical care and intensive care and providing respiratory interventions and positioning and early mobilization when safe to do so, and all the kind of tools that we have to work with these patients that are so important, not just from a rehabilitation perspective, but can actually make a difference in terms of the medical journey of that patient as well. And we saw that increasingly in COVID-19. The challenge is that we do need to be appropriately skilled. It needs to be within scope of practice. And we need to be doing that as part of a team approach as well. So it's not just something that we can do on an individual level or we can implement without kind of putting all the right blocks in place to make that happen. But we do know that it is so critical for patient outcomes. So early mobilization from the critical care point, we know can shorten length of stay in hospital, can reduce delirium, can really reduce other complications like contracture and things as well. So it can have a huge impact, not just on individual patients, but on the overall efficiency of the health response. And that's so critical in emergencies where we have these huge numbers of patients, is how do we make the health system more efficient? And one of the ways that we can do that is by getting rehabilitation professionals involved in the patient journey as early as possible, getting them better faster, preventing complications, and enabling them to get out of the hospital by providing them with the early rehab and the right equipment that they need as well, like crutches, to be able to safely do that so that they're not then placed at more risk when they leave home. So that's why we're constantly advocating to kind of shift the idea of rehabilitation as being this end stage process to one that really begins at the same time as other care does, so that we can do all of those things. And we do know that you get a much more efficient health system where we're able to do that. But you can't do it at the push of a button. Mm-hmm. You need all of the blocks to be in place to be able to do that safely.
Mm-hmm. Yeah, Pete, you're absolutely right, and I'm kind of paraphrasing this next question that popped up in the chat, but it's as we increase the efficiency of a system, and that, like you just said, that could be, the input of actual rehab providers, or, even possibly rehab skills or discharge rehab skills to the other providers, physicians, nurses, so that the flow through can be more effective or at least efficient. I guess the question is, how do we support, and this came up in the chat, but how do we support the discharge, or to what extent is that discharge back to a community that might not exist in the same way? It might be a new community. It might be a different type of community. I know in Nepal, one of our partners, IOM, the International Organization for Migration, helped create a step down facility, let's say, to increase the throughput from acute care to this step down and then into the community, which I think might be offer a partial solution. But maybe some commentary from you around, how do we support that discharge to quote unquote home? Oh, I think you're on mute there.
Thank you. Yeah, it's partly about being systematic about this and actually having formal approaches where we put systems in place to ensure that people are followed up. I think one key thing is that we need to recognize that often patients will not spend long in hospital, and follow-up may not happen immediately just because of the sheer volume of cases and the breakdown of existing systems that existed. What that means is we need to do two things. We need to put a much greater emphasis on patient and caregiver education. So moving the power from the therapist to the patient and to their family and caregivers to be able to understand what the rehabilitation process is and the importance of what we're doing. We also need to really educate them around both the prevention and the identification of complications as well, because one of the main things that we need to do in emergencies is manage risk. And then what to do if they do experience complications, where to go and to seek help, because I think far too often those patients will be discharged and not know essentially what's normal and what to expect, and will then present at a much later stage with what would have been preventable complications, whether pressure injuries, joint contractures, and other related things that we could have prevented. So I really think pushing, first of all, from a risk management perspective on that education, I think having resources that are preset, patient education resources and materials, can help with that to a degree. But then it's about, as you say, actually actively thinking and planning to reorientate the services that we have available. So services that were available pre-conflict are not likely to then meet the needs of patient during the conflict and post-conflict. So the idea of step-down facilities is one solution, which is if you know that patients are being discharged to tents, or to other situations, if they don't have a safe place to go where they can continue to receive some degree of sort of nursing and rehabilitation care, but they're medically stable, we need to get them out of the hospital where they're taking up a bed which may be needed for the next mass casualty situation, but we need to keep them safe. And so step down is a really nice example of that, where you can transform spaces with less medical cover than you would need for a space that has patients with acute needs, into spaces which are more dedicated to rehabilitation and nursing care, where patients can get more intensive input, but it requires investment in the space. You need the equipment in place, you need the electricity, you need the water, you need all of the infection prevention and control to be able to do this safely. And those patients will also be there for a limited period of time, and then they will have to leave to bring more patients through, and so will be displaced in the community. And there we have the same problem, and then it becomes about, we can't fix, unfortunately, displacement for everybody. We can't control the situation that people are being discharged into, but we can make sure that they are provided at least with the minimal equipment that they need, and that they're prioritized for other support that they may need as well. So that means if they're going to a tent, do they need a pressure mattress? Do they need a more specialized wheelchair? Do they need crutches? Do they need bladder and bowel materials for that side of care so they don't get problems? And do we need to actively work with other agencies to make sure that we can send them to places where we know they can access accessible toilets, accessible showers, food distributions, and so on. So there's a whole piece of kind of strategy and coordination that needs to be done to be able to keep people safe in that situation.
Yeah, thank you. Let me just take it a little one step further because in the chat earlier there was and forgive me, our colleague asked the question. I didn't put down your name, so please put it if you can now. But it was around the extent to which organizations of persons with disabilities themselves or their families or their communities participate into, I suppose, the planning through to the, delivery of services or a continuity of care. And maybe I'll ask you, Pete, to say a few words, and then I'll bring in Thanos because I think he has a point to make on that one. And I guess the point is, of course, all of us are rehabilitation professionals and providers, so we would agree with the inclusion, but taking it one step farther, that can be exquisitely challenging, time-wise, language-wise. I mean, so there are some complexities to that, and it's not because of lack of attempt or willingness, but it's difficult sometimes. So maybe offer your points, and I'm just going to tee you up, Thanos. We can get you to have a point to make as well after Pete's done. Thank you.
Regarding disability, I think it's a challenging issue. So disability is about much more than just rehabilitation. And I think in the past, maybe rehabilitation providers have thought that it's our job to kind of represent people with disability and to address the issues. And actually, what we should be doing is it should be the organizations of people with disability that are pushed to the forefront of this. And so increasingly what we're seeing is that disability is positioned as an intersectoral or a cross-cutting issue. So people with disability in a conflict need sometimes rehabilitation, not always, need sometimes assisted products. Sometimes they should be provided by a rehabilitation professional. Again, not necessarily always. It's just a replacement of an existing device and it doesn't require any specialist fitting and things like that. But they also need access to food distributions. They also need access to accessible shelter. They also need access to education. All of the things that anybody else needs, where they face additional barriers that are put in place for them, not as a fault of their own, but barriers that are a consequence either of the conflict or of the society or of the situation in which they find themselves in. So really, what we hope to see is representation of people with disability in all of the different sectors that are involved in the humanitarian response, whether it's a conflict or somewhere else, and that it's considered as essentially a protection issue across all sectors. So some people with disability, again, not all, some people with disability are more vulnerable in these settings, and that we as actors have obligations to reduce the barriers that they face. One of those things can be rehabilitation. And rehabilitation, again, when we talk about maintaining essential services, is incredibly important for some people to maintain health, but also to maintain access to everything else that they need as well.
Yeah, well said, Pete. Can we open up Thanos? Maybe you wanted to make a point.
Thank you very much, colleagues. So the point that I would like to make for the inclusion of people with disabilities is that the last years, when it comes to humanitarian grants, by definition, they are taken into consideration when it comes to project planning. They're making part of the planning phase, they're making part of the implementation phase, and there's different ways to monitor this when the implementation starts. So besides the internal embedded WHO monitoring procedure, there's also third-party monitoring that makes sure that whatever we do, we make people with disabilities, mobility disabilities, or other disabilities into consideration. Of course, as my colleague Pete has clearly stated, it's easier said than done, and different contexts allow for different margin of such inclusion. However, from the moment I started working as professional in conflict until now, I have seen progress, and I'm pretty confident that the more we advance, the more people with disabilities will be better included because they make part of the entire process. Thank you very much.
It's a great point, Danos, and I think I don't know if somebody can put in the chat as well. There's an incredible guideline called the IASC guidance on the inclusion of persons with disability in humanitarian action, which really sets out key steps across all the different sectors that governments and also humanitarian agencies can take, and I would recommend it as reading. It has a strong section on specific needs for injury rehabilitation as well.
Well said. Thank you very much, the two of you, for that, for those answers. We're just sort of wrapping up things at this stage. I'm going to ask another question or two, but if there are other questions, please put them into the chat, and we will take note of them. Make sure.
La 31e édition de ce concours.
I think. There we go. Yeah. So if you have other questions, please go ahead and put them in the chat. And what we can do is take note of them and make sure we get some answers. A little point here also, everybody who is registered today will also be registered for the next session, which is on April 9th, I think. So there's no need to necessarily register for that. You'll be automatically registered. But if you have others, yes, thank you. That is right there. The next is the expert panel. So I think that'll, just so you know that you'll be pre-registered for that anyhow. Maybe just one last question, Pete, and by the way, I'm humbled by the list of names who are here today. Many of them who are the physiotherapists and the occupational therapists and are all rehabilitation colleagues in conflict and fragile settings, who would undoubtedly have plenty of commentary of the how-to. So we'll have to figure out a way to that these are all conversations, bi-directional, and so that we can all learn from each other. But there was a previous question that had to do with sort of, the role of, let's say, academic institutions, and it brings up an interesting point, and it's a broad one, and we're addressing it here and through this whole series, but building capacity, competency for rehabilitation providers in fragile and conflict affected areas is often different than a traditional training program. So what role, Pete, how do you foresee the future of building that capacity of maybe a cadre of rehab providers ready to respond? And certainly you personally and the EMT UK group and in Australia have created some really important strategies around having a core of providers ready to be involved. But maybe provide a little commentary on this, and maybe you could wrap up with some other thoughts that you have, and then we're going to close the session. So we'll kind of give you one of the last words.
Right. Thank you. I think broadly on the kind of academic institutions, they can play a huge number of roles. So training is obviously one part, and I'll mention that more in a bit. But I think not only that, but the research component is so critical where we have gaps as well. So it's an area that I'd really like to stress on, where people can contribute. But also we see in some instances institutions themselves responding, where they have clinical faculty themselves that they can pull together under their governance and can actually mobilize teams under the sort of clinical governance and the operational support of the institution. So we've seen that in a number of instances as well, and that's been very, very welcome. On the workforce side of things, I think, first of all, we will very, very soon be publishing a competency framework specifically for rehabilitation professionals working in emergencies, which I think will be a big step forward, because until now we've had basic guidance within the EMT minimum standards that we have, but this will really be a much more comprehensive competency framework based on work that WHO has already done in this area. I think we present this as being a bit of a pyramid system, right? Where different people need different skills depending on where they're working. So at the bottom of the pyramid, the largest proportion of the workforce probably need, as part of their undergraduate training, an introduction to the type of hazards that they are likely to face in the country that they're being trained to work in. and equipping to know what their role would be if they were working in a general hospital setting in that type of role. Just introductory so that everybody has the same baseline understanding. I don't think we often train enough about trauma in undergraduate curricula. I think it's a neglected area in many, many undergraduate curricula, and we notice that when we have conflicts is that we don't teach so much about trauma, and not trauma generalists as well that can manage a whole host of different traumatic conditions. People will often subspecialize quite quickly in different areas. Okay. So that's your baseline. Above that, we need training that's kind of on-the-job training for people that are working in hospitals that are likely to, or other rehab services that are likely to receive patients in emergency situations. So that's specific training for them about their role and where they fit within that system, and then the clinical skills that they need to be able to carry out their role safely. Then above that, we have a smaller cohort, again, of people that might be mobilized within the country to other places. So they will move outside of their place of work to go and respond to emergencies, and they need training about the differences in doing that versus working in your normal place of work. And then at the very, very top of the pyramid, we need leaders in all of these contexts. We need leaders that understand the jargon of humanitarian response, and we're terrible in humanitarian responses for jargon, but they need to understand who all the different actors are, what all the systems are that are in place, and where they fit within those systems, and be able to communicate effectively with other humanitarian responders and leaders as well. So we need this kind of comprehensive approach. This is supported by something that WHO called the Global Health Emergency Corps, which is the idea that every country and every professional discipline needs an approach like this, where they view their health workforce from this perspective, and rehabilitation professionals are no different. So starting from undergraduate training, introducing people to the basics of the role, and then moving up as people progress and getting more and more specialized as things go. It's the future for sure, and it's something where I think we hope to see sort of positive changes.
Yeah, thanks, Pete. I couldn't agree more with all of your points around maybe training modules across all of our professions, which are jam-packed with information, and it is all essential. But the question sometimes is, does it reflect reality? And I say that as an educator. I do want to just sort of bring things to a close and acknowledge all of the important points that have been made on the chat, including many occupational therapists and all of our professions here. So really appreciate that. Just to reiterate, you don't have to put your email in the chat. If you've registered for this one, you are automatically registered for the other one. So, but if you feel there are other organizations who would be interested, make sure you put that in the chat. So I'll wrap up here and just say a big thank you to you, Pete, for your presentation here today. You're the utmost professional in this field, and thank you for all that you've done in the past and what you'll be doing into the future. Pete is very accessible and always ready to answer questions. So, thank you for that. And thank you to all of our colleagues from the World Health Organization who are here. Thank you to my colleagues from World Physiotherapy who stepped in to arrange the webinar here today. And with that, I will wish you all, unless there is something, and I know my colleagues will send me something in the What's up? If I've forgotten, I don't see anything. So thank you very much, everybody. Enjoy the rest of your day. For those of you colleagues who are in conflict and fragile settings, we stand in solidarity with you. That always is the reality, although it doesn't always feel like that. But I think here today we're on a new journey to start to build that solidarity around the world. So with that, thank you so much, everyone, and we'll see you at the next one on April 9th. Thank you.
Thank you.